welcome to New Retina Radio Journal Club with VBS. My name is Ben Young. I'm at the KCI Institute in Portland, and today I'm joined by Josh Uhr, who's at Mid-Atlantic Retina in Philadelphia,
Hi, Ben. Thanks for having me.
and Lediana Goduni of Retina Associates of Cleveland.
Hi, Ben. Thanks for having me as well.
Yeah, thanks guys for coming. Today we're going to be discussing a paper titled Clinical Outcomes of Faricimab in Patients with Previously Treated Neovascular Age-Related Macular Degeneration. It's written by Sagar Pandit and mostly the group from Mid-Atlantic Retina, and it was published in Online in Ophthalmology Retina October 2023. I think this is a really interesting paper. Josh, can you start us off by summarizing what they found in the paper?
Yeah, of course. So the purpose of this study was to assess the anatomic and functional outcomes in eyes with wet AMD that were previously treated with anti-VEGF therapy and switched to intravitreal faricimab. So it's a retrospective interventional consecutive case series of 218 eyes from 191 patients at Mid-Atlantic Retina and Wills Eye Hospital. The authors looked at patients that were previously treated for wet AMD who were then switched to and received 4 or more consecutive faricimab injections from March through November of 2022. The mean age of the patients included was 79.9 years. So what did they find? Well, before being switched to faricimab, these patients had undergone a mean of 34 previous intravitreal anti-VEGF injections. And they found that after switching to faricimab and receiving at least 4 faricimab injections, the average visual acuity did improve slightly from about 20/76 to 20/71, but this was a non-significant trend. They also looked at various anatomical outcomes, and they found that the maximum height of the fibrovascular PED decreased significantly from about 195 microns pre-switch to about 165 microns post-switch. The central foveal thickness also showed significant improvement, reduced from about 355 microns pre-switch to 307 microns post-switch. And the proportion of eyes with intraretinal fluid decreased from 36.7% to 24.8%. And similarly, the proportion of eyes with subretinal fluid decreased from about 53.2% to 26.6% pre and post-switch, respectively. And all of these anatomic outcomes were statistically significant. So the authors concluded that intravitreal faricimab may improve anatomic outcomes in patients with previously treated wet AMD while maintaining vision in the short term, and also that transitioning to faricimab is associated with a significant anatomic improvement, meaning reduction in intraretinal and subretinal fluid, decreased fibrovascular PED height, and a decrease in central foveal thickness.
Yeah, thanks, Josh. I think that's a great summary of a paper that's pretty dense with a lot of different findings. Lediana, let me throw this to you just for initial reaction to this paper. Like, what do you think of it? What really strikes you from their findings?
Well, agreed. Great summary, Josh. I think it's a really nice paper, kind of looking at real world data. I mean, when new medications come out, most of the patients that will get it tend to be patients who have already been treated previously, and most of the patients we see are follow-ups rather than new patients. So it's really nice to have this real world data. And I like that they kind of included patients who had received all types of anti-VEGF injections and not one specific one. So it makes it more generalizable. And, I think the results are pretty consistent with what we generally see in practice, and what other studies have shown is a really great ability of faricimab to dry up the retina. So, as the study said, really good anatomical outcomes, and, good vision, not necessarily superior, but at least maintaining good vision. And, this didn't follow up patients too long, but there was kind of a trend, and we can discuss that more later, toward a slightly increased interval between those the last injections that the patients received. So, potential for further extension of these patients. So I think it was a very useful study.
Yeah, great. I think to me, that's one of the big things, is like that extent hopeful, that teaser of there might be, maybe we'll put more time between injections for these patients. Josh, what do you think, having reviewed the study too, did you have the kind of the same takeaways as Lediana, or anything different there?
Yeah, absolutely. So Lediana mentioned, and I agree with her that it's really nice to have data on how these drugs work in previously treated patients, because the clinical trials are all treatment naive patients, and really what the clinical trials do well is help us assess durability. How long we can get between injections, which is an important endpoint. But in the real world, I think many of us use these drugs first for our treatment-resistant patients, which the trials are not really designed to analyze and to show us how these drugs work in that population. So I think it's really nice to have data like this that supports that these drugs, the newer, what some people are calling the next generation anti-VEGFs, how they perform in patients that have been previously treated.
Great points, Josh. I totally, agree with what you're saying. I'm looking forward to going into a more in-depth conversation about these findings right after the break. And welcome back to the new Retina Radio Journal Club with VBS. Let's get into a longer discussion about the paper Josh Uhr just summarized in that first part of the episode. So, I think for me at least, what I want to explore is how much will these findings change for clinical practice? Like, how is that going to inform what we're going to do? Because I think broad takeaway for me is that you will basically get some anatomic improvement by switching these patients, but we didn't really see, there was a trend towards functional improvement, but it wasn't proven. So, Lediana, maybe I'll start with you. What do you think about that? Like, how is this going to change what you're going to do?
Yeah, I think that's a great point, because at the end of the day, we care about the OCT and vision too, but patients really only care about vision. So for me, I thought an important point is to note that prior to being switched over to Faricimab, patients received an average of 34 intravitreal anti-VEGF injections. And basically, they were getting them about every month because the interval pre-switch was about 35.7 days. So these were very, patients who were very burdened by injections, and they were active during that whole time because the whole reason for switching was either, they had fluid. So these patients were chronically, basically uncontrolled. And for me, the takeaway is perhaps we should be switching these patients earlier, and an earlier switch might make, a more meaningful difference in vision. If these patients don't have persistent fluid for that long, we can make some gains on the visual acuity grounds by switching them earlier. So I think that's an important point for me from this paper.
Yeah. And Josh, do you have like a cutoff on when you switch patients at this point? Or like, I guess now that know the results of this paper, like, is it at injection number 3 or is it injection number 4? Is it based on how they're doing? Like, what are you doing right now?
Yeah, so I would say I don't have any hard and fast criteria, but I am fairly quick rather to switch patients to faricimab or high-dose aflibercept, which is not the subject of this study, but one of the newer agents that we have. I agree with Lediana. I mean, if we can control the disease better earlier, these patients presumably will have better outcomes. Like Lediana already pointed out, these patients had, in this study, a mean of 34 previous injections. So the authors do write that these patients probably already reached like their maximum, visual improvement. But I do still think it's worthwhile to control them anatomically because the vision data that we have in this study is short term. So I would be curious to see longer term data, and I'm sure in time we will, but if you can control the intraretinal fluid, which has been shown in many studies to be associated with worse vision outcomes, presumably the paths of these patients in terms of functional outcomes will diverge more at some point in the future. So earlier switch, I think, is a great idea, or starting patients on these drugs. In my practice, I give patients a fair shot at some of the older agents, and if they're just not well controlled, or if I can't extend them out longer, then I'm pretty quick to switch.
Got it. And Lediana, are you starting anyone on faricimab, going along that topic, or do you also think we should try to give them a fair shot with a kind of legacy anti-VEGFs?
Well, a lot of, the treatment decision when a patient first comes in is unfortunately dictated by insurance a lot of times.
Yeah.
So most of the time they get whatever insurance pays for. If I can give them brand name drug, I do, and then whatever insurance pays for. If there's some insurances that will pay for Vabysmo, and yeah, I give those patients Vabysmo. I don't have a bias necessarily that way. So I think that if it's for me, if it's approved, if that's the first agent they can get, then yes, they do.
Yeah.
Yeah, I will point out too, to Lediana's point, of course, insurance like dictates everything that we do, right? They sort of call the shots on what we can give, at least initially. But I've experienced, I'm curious to know if you guys have as well. I have a lot of patients coming in requesting a certain drug because they see the commercials. And, I find it hard to justify not switching them to an agent that potentially could get them to longer intervals if the insurance will, pay for that agent. And the safety profile seems to be similar to the other drugs that we already have. It seems like the benefits are clear, and and patients know that because they're seeing it on TV.
Yeah.
That, and we shouldn't undermine the interval extension, because in this study it wasn't a long follow-up, but they said between the third and fourth Faricimab injections, the interval between injections increased to 43.1 days as opposed to the pre-switch interval, which was 35.7 days. And I mean, that's a little over a week. That's a big difference for some patients. They all have anxiety about coming in to get injections, and obviously it also decreases the burden on the practice and the whole system. So I think that's important. And like Josh said, even if they're doing very well on an agent that's every 4 weeks, if you could give them a longer interval, I think that's great for the patient and great overall for our whole system.
Obviously, vision is our main goal, but I think interval extension is like alone an independent, worthwhile endpoint.
Oh yeah, I think it's a huge, probably the second biggest thing for patients, right? Over vision, or for some patients, is more important than their vision.
Yeah.
It's more, and yeah, I like your point about the patients bringing up because of advertisements, and I like to think like, oh, I'm not going to get impacted because a patient's bringing it up because of advertisements. But sometimes, I have some patients who are like on, aflibercept Q6, Q8 weeks, and then they bring it up like, maybe we can get you farther, right? Like, Q10, Q12 weeks would be huge for some patients. Like sometimes it's worth an effort, I think. So yeah, that it does kind of jostle me out of like the normal flow when they bring it up. And I think papers like this are nice to remind us that we don't have, just because someone is doing well on Q6 weeks of aflibercept doesn't mean that we can't maybe do better with other agents like this. So not that this study directly tested that by any means. So
increases, compliance and everything too. If they don't have to come as much, I think they're less likely to miss appointments and things like that.
Yeah. This paper seemed to show there was both improvement in IRF and SRF. I think, Josh brought up in the beginning. Does the distinction matter to you guys? Like if they have no IRF, just SRF, do you guys think it's still worth trying to switch to faricimab, for example?
So because I know, studies have shown that obviously intraretinal fluid is more detrimental toward vision, and some subretinal fluid could potentially be tolerated. And I have some patients who are on either, these newer, like Josh said, newer agents who have stable vision. Let's say they're like at 20/30 and, there's like a trace amount of subretinal fluid and they want to be extended. And I'm okay with that. But if you could have them completely dry, then that's even better. So I think it's worth trying to make them as dry as possible,
Josh, if you agree, then I'm going to ask you, what do you think about PEDs? If you got like a big juicy PED, because they showed improvement there.
Yeah, they
But
did. So, well, first of all, I will say I do agree with Lediana. The other thing I'll say about SRF, which I'm much more likely to tolerate than IRF, but I get nervous to start extending patients with SRF. So it goes back again to the question of durability. So if I can switch them to a newer agent and maybe still tolerate some SRF, but even at longer intervals, I think it's worth it. I don't treat PEDs alone. I know there are some people that do, and there's some discussion about how that is a marker of disease activity that is worth pursuing with injections. But if there's no subretinal or intraretinal fluid, I don't target solitary PEDs.
I agree personally.
I think that's what a lot of people do. But it's interesting, I mean, I'll take it if it gets smaller. I won't
Yeah.
complain,
Yeah, absolutely.
as
But
well.
one of my concerns, especially if it's a really large PED, is you could give this patient a big problem if you cause an RPE tear. So
Oh
that's
gosh,
always in the
yeah.
back of my mind.
Yeah. Always the lingering fear.
Yeah.
And yeah, but I think if anything, this paper is a nice preview or maybe advertising for what I hope is a follow-up paper looking at treatment interval, which I think we're all going to really look forward to. And again, to make it clear for maybe future listeners, at the time that this paper was released, Faricimab had not been out on the market for that long. So I think this is like probably the most like data that we could have, uh, probably, based on their study methodology. Anything else, guys, that you want to closing thoughts you want to throw in before we close?
I think it's a great starting point for gathering more data in the future.
Yeah, agree. Absolutely.
Great. Well, Josh, Lediana, I want to thank you both for coming on and discussing this with us. And I want to thank you, the listener, for downloading this episode of New Retina Radio Journal Club with VBS. And stay tuned for future episodes.